we will discuss about P wave of ECG. Characters of normal P wave: width or duration in time horizontally zero point 0.1 second or 2.5 small square or less than 3 small square. Height 2.5 millimeter or 2.5 small square and less than 3 small squares. Height into duration is equal to 2.5 into 2.5 small squares. P wave is better seen in lead 2 as atrial depolarization is towards lead 2, also seen in V1. P wave is upright in all leads, mainly lead 1, lead 2, ABF except AVR. P is inverted in AVR and occasionally in AVL. P wave in V1 may be biphasic, equal upward and downward deflection, notched and wide. Activation of right atrium produces positive component and activation of left atrium produces negative component. Normal P is rounded, neither peaked nor notched. Now, abnormalities of P wave. P wave may be absent, tall or small, wide, notched, biphasic, may be inverted, variable and multiple. Now, causes of absent P wave. The causes are atrial fibrillation. P is absent or replaced by fibrillatory F wave. Atrial flutter. P is replaced by flutter wave which shows sawtooth appearance. SA block or sinus arrest. Nodal rhythm, abnormal small P wave. Ventricular ectopic and ventricular tachycardia. Supraventricular tachycardia. P is hidden within QRS due to tachycardia. Hyperkalemia, idioventricular rhythm. Causes of tall P wave. Tall P is called P pulmonale. Height is more than 2.5 millimeter, that is more than 2.5 small squares. It is due to right atrial hypertrophy or enlargement. Here the ECG shows tall P wave. The P is 4 millimeter in height. Now, causes of small P waves: atrial tachycardia, atrial ectopic, nodal rhythm, high nodal, nodal ectopic, high nodal. Causes of wide P wave: P wave is broad and notched, called P mitrally. Duration is more than 0.11 second or more than 2.5 small squares. It is due to left atrial hypertrophy or enlargement. In V1, P wave may be biphasic with a small positive wave preceding a deep broad negative wave, indicates left atrial enlargement or hypertrophy. This ECG shows wide notched P wave, that is, and in lead 2 and in lead V1 there is biphasic P wave. Causes of inverted P wave: negative in lead 1 to ABF, incorrectly placed leads, that is reversed arm electrodes, dextrocardia, nodal rhythm with retrograde conduction, low atrial high nodal ectopic beat. Now, causes of variable P waves. Presence of variable P waves indicates wandering pacemaker. Causes of multiple P waves: consecutive 2 or more, AV block, either partial or complete heart block, SVT with AV block. Now we will discuss about PR interval. Characteristics of normal PR interval. It is the distance between the onset of P wave to the beginning of Q wave. If Q wave is absent, then measure up to the onset of R wave. It is the time required for the impulse to travel from SA node to the ventricular muscle. The impulse is transmitted to ventricle via AV node. PR interval varies with age and heart rate. PR interval is short if the heart rate is increased and long if heart rate is decreased. Normal PR interval is 0.1 to 2.2 seconds. That is maximum 5 small squares. In children, upper limit is 0.16 seconds. In adolescent, upper limit is 0.18 seconds. In adult, upper limit is 0.22 seconds. PR is short if it is less than 0.1 second and long if it is more than 0.22 second. Abnormalities of PR interval. PR interval may be prolonged, short or variable. Now, prolonged PR interval, that is more than 0.2 second, It is due to first degree heart block. Causes are ischemic heart disease, occasionally in inferior MI, acute rheumatic carditis, myocarditis due to any cause, atrial dilatation or hypertrophy, hypokalemia, drugs, digitalis toxicity, quinidine, occasionally beta blocker, calcium channel blockers, that is verapamil. Now short PR interval, the PR interval less than 0.12 seconds causes are WPW syndrome. We all know it. Old Parkinson-White syndrome. There is also delta wave. LGL syndrome, Lewin-Gannon-Levin syndrome. There is no delta wave. Nodal rhythm, nodal ectopic high nodal. Occasionally, if dissociated beat is present, and also in infant, steroid therapy. Variable PR interval causes a Wenckebach's phenomenon, Mobius type 1. There is progressive lengthening of PR interval followed by a drop beat, partial heart block, Mobius type 2. PR interval is fixed and normal, but sometimes P is not followed by QRS. 2:1 AB block, alternate P wave is not following by QRS. Complete AB block, no relation between P and QRS. Wandering pacemaker, variable configuration of P.